All right, so I think we are live. Hello, everyone. Welcome to this session on the updates in stroke guidelines 2026. First of all, before I start, can you just let me know in the chat box if the audio and video is good? And I'm just waiting for your comments so that we can start the session. Hello, everyone. Hello, Dr. Firdaus, Dr. Jane. Good evening. Right. Okay, I think it's all good. So hello everyone, this will be a session wherein we'll be discussing about the updates in the stroke guidelines 2026. So as you all know, we have had this AHA stroke guidelines in the year 2018, which was then followed by an update in the year 2019. So whatever updates that we'll be discussing will be in relation to the 2019 guideline. So we'll just have a comparison. Well, in this session, we are not going to go for a detailed look at the 2026 stroke guideline. It'll be more of a comparison with the 2019 guideline and focusing on the updates so that you get a clear view on what has changed. Okay. So to all our dear students listening, we'll be sharing the PDF of this session in the group. So in our academic WhatsApp groups, I'll be sharing the PDF after this session. So do not worry, you'll have a lot of slides in this session, but just stay calm and relaxed. Okay. So as you listen to this session, just be with an open, relaxed mind. You can just sit, stand, sleep, or not, don't sleep, but you can do whatever you want, but just stay calm and relaxed. That's what I want to tell you. We have compiled all the updates. So with me, I've got Dr. Pooja Anand, who has done DM Neurology from AIMS Delhi. And she's also a neurology faculty at the DocTutorials Medicine Residency Program. So me and Dr. Pooja will be doing this session together. And I'm so happy to do this session with Pooja. She was one of my dear students, during her preparation for NEET PG and also the INI-CET exams. And a wonderful, wonderful academic mind, a brilliant girl, and I'm so happy to see her coming to this level. So happy to have you with me, Dr. Pooja, for this session, and welcome.
Thank you. Thank you so much, sir, for that warm welcome. And it is my absolute honor to actually, be with you in this session together, and not as a student, but as a faculty. And as you rightly said, that I was your student not only in my MD preparation, but also in my DM preparation, not just the entrance, but also the entire DM neurology course. And even till date, if I have to take some advice, it is always you are my go-to person to ask. So it's my absolute honor to have this session with you, sir.
Yeah. So Pooja, I think we'll just start with the guidelines. Okay. So to all dear students, again, let's start. We'll be going in a fast pace, and as I said, we'll be focusing mostly on the updates. Okay. Okay. Right. Now, this session that we are doing is in continuation with the series of sessions that we have got in the DocTutorials Medicine Residency Program. So in case you have not enrolled for this program, it's a unique course wherein we have got a team of super specialists discussing about the theoretical aspects as well as the practical aspects. So you will not just see theory videos subspecialty wise, you will also come across clinical cases, viva sessions, long essay discussions, examination videos, everything that you need during your medicine residency, you will find in the medicine residency course. And this we have as a separate course other than the successfully running NEET SS and INI-CET courses that we have got, right? Okay. Now, so you can just scan the QR code. So on the left-hand side, Neurology Unplugged is the Instagram page of Dr. Pooja. She has done some very good academic content in that Instagram page. So you can follow Dr. Pooja in that Instagram page. And in case you are not there in our academic WhatsApp groups, you can inbox me. This is my Instagram ID, dr_Rahul_Rajeev. You can message me in Instagram. You can send me a message. I'll be sharing with you the link of our academic WhatsApp groups as well, right? All right. So as we move on to this guideline discussion, I'm sure this is something that all of you know regarding the class of recommendation by the AHA-ASA. Class 1 is strong recommendation. Class 2A, you've got where the benefit is above risk and it is a reasonable recommendation. Class 2B is a weak one. Benefit more than or equal to risk may be considered. Class 3, no benefit, wherein, it is not that recommended. Class 3 is harm, where the risk is actually, superseding the benefit. Okay, this is something that all of you might be knowing, right? All right. So coming to the updates, the first update is in relation to the choice of thrombolytic agent. Very, very important. If you look at the 2019 guidelines, tenecteplase at a dose of 0.25 mg per kg had a class 2B, which is a weak recommendation. And at that time, it was suggested as an alternative to tenecteplase for patients without contraindications for thrombolysis who were eligible for mechanical thrombectomy, because it is given as a bolus dose, especially in patients as a bridging therapy, bridging thrombolytic therapy before the thrombectomy. It was preferred. So that was the choice. And what you're seeing on screen is the 2019 guideline screenshot. You can see it was a 2B recommendation. But as we come to the 2026 guidelines, the tenecteplase has been upgraded to a class 1 recommendation. It is now considered as a reasonable and equivalent option to tenecteplase for all eligible adults presenting within 4.5 hours. So it has got not just an equivalent option, a recommendation, but you all have to understand that there are many pharmacokinetic advantages of tenecteplase over the alteplase, and there is a chance in future that it can definitely supersede that of alteplase. Okay, that is what you've got to understand. No, so this is just a comparison between alteplase and tenecteplase, and a faster delivery with a simplified workflow definitely gives a tick for tenecteplase, right? All right. So the guideline also mentions regarding the weight bands of tenecteplase. You can just go through this once I share the PDF in the group, right? Now, another important point that I want to share with you is, if you look at the 2019 guidelines, they are mentioning about the higher dose tenecteplase, that is 0.4 mg per kg, that might be considered with a class 2B recommendation as an alternative for patients with minor neurological impairment despite not being proven superior. So basically, if you remember, there is a NOR test 1 trial, if you remember, okay, the NOR test 1. So in NOR test 1, the strokes that were being taken were minor strokes. So at a dose of 0.4 mg per kg, the tenecteplase was compared with the alteplase. So according to the 2019 guideline, it actually had a 2B recommendation. Okay, so this was for patients with minor neurologic impairment. But we have seen with NOR test 2 about the risk of bleeding associated with the higher dose tenecteplase, which is why in the 2026 guideline, it explicitly recommends against the use of the higher dose of tenecteplase at 0.4 mg per kg. So this is classified as class 3, no benefit. And as I said, it is in relation to the NOR test 2 trial, wherein you had this patients with larger strokes, and there was evidence of symptomatic intracranial hemorrhage as well. Okay, now I hope that point is very clear. Now we move on to the next aspect. This is regarding the extended time window for thrombolysis. I want all of you to listen to this carefully. An important update is coming up, Dr. Pooja, regarding extended window thrombolysis. Your comments on that?
Yes, so extended window thrombolysis is something which is recently updated in the 2026 guidelines. And the sole concept that you all need to understand is that now with these guidelines, we are becoming very aggressive with the treatment of stroke, be it in the form of intravenous thrombolysis or be it in the form of endovascular treatment, because the sole idea is that we need to salvage whatever brain tissue we can. And the golden window we have is the first 24 hours, because beyond that, then the stroke is not just a burden for the patient but also for the caregivers. So that is why we have this caveat of extended window thrombolysis. Now, carefully look at the time intervals that they have specified. Now, the first, what we used to have was just a wake up stroke, right? But now, even the wake up stroke has to be stroke symptoms which occur within 9 hours from the midpoint in the sleep. Okay, so this is very important. Now, even for the wake up stroke, you need to know that it should be from 9 hours from midpoint in sleep. And even with patients where you know the last seen well, or the last known well that we commonly abbreviate, up to 9 hours. So now from beyond 4.5 hours, we're going up to 9 hours. So these are the two important criteria where you can consider extended window thrombolysis. One is when you have the symptoms within 9 hours from midpoint in sleep, or the last seen well is from 4.5 to 9 hours from last known well. Now, what you need to consider that in these patients, you need advanced imaging criteria. The conventional imaging criteria will not be sufficient alone. So you need advanced imaging criteria. And what are these criteria? Either there can be a DWI or a flare mismatch, or it is a perfusion based mismatch. Okay, so the two important points you need to remember. Number one, which patients you will consider, and number two, that you need advanced imaging criteria. The normal CT, normal MRI, normal angios are not going to help you decide thrombolysis in these patients.
Right. And one query by a student, Lucky Singh is asking what is meant by midpoint in sleep. So if you can just give him an example of this midpoint in sleep.
Okay, so like if you have a patient who came to you, say at 11 a.m. in the morning, right? And the relatives say that, the last we saw this patient was at 12 in the night, okay? And then when he woke up at around 10, so the patient was found to have, say, right hemiplegia, which was there. So the 12 to 10, so you have that big window which is there. So the midpoint is going to be somewhere around 4 to 5. So from that midpoint till 9 hours when the patient has presented to you, so that will be how you will be calculating that.
Right. Right. And also, Pooja, I think in comparison to the 2019 guidelines, for wake up stroke at that particular time, they had mentioned only regarding the diffusion flare mismatch.
Yes.
But now they've added regarding the perfusion based mismatch as well. And that is another addition that has come up in this guideline as well. Right. Okay. Right. So shall we move forward? Yes. Right. Now coming to disabling versus non-disabling stroke. A mention of this was there in the previous guideline as well, but we will see certain solid statements in the new guideline. So watch out for what those solid statements are. So Pooja, if you can go through this.
Yes. So this is also a very key update from the previous ones, and this has a very large implication where you as residents decide the thrombolysis. So initially, what we used to decide thrombolysis was based on the NIHSS score. Okay, so that was a score that we used to calculate. And based on that score, we used to decide whether the patient was going to be eligible for thrombolysis or not. But as we saw that this score had a lot of caveats, it had a lot of shortcomings which were there, such as that it was not reflecting the posterior circulation stroke, it was more biased for the left-sided strokes and a lot of them. So as a result, now this entity has been replaced with the deficits, which are the disabling deficits, right? So the key word here is the disabling deficits. So this is important for patients who are coming to you within, so it's important that it's a disabling deficit, number one. Number two, these patients are coming to you within the 4.5 hours window. And number three is that in this window, you do not need the advanced imaging selection criteria. So there are 3 points that I want you all to remember from this. Number one, disabling deficits. We will see what are these disabling deficits, how we define them. Number two, they have to be there within the 4.5 hours window. And number three, that there is no advanced imaging selection criteria, because that is the criteria we use for the extended window thrombolysis, not within the 4.5 hours window.
Yeah. And for the students, if you look at the previous guidelines as well, therein also thrombolysis was not too much dependent on the NIHS score. But, if you look at the guidelines carefully at 3 to 4.5 hours, if the NIHS was more than 25, it was said to be not thrombolized, do not thrombolyze. But here they have made a solid statement, which was lacking in the previous one, regardless of the NIHS score. That is an addition in this particular guideline. And Pooja, if you can just tell them, what all deficits are clearly disabling and what are the ones that may not be a clearly disabling deficit, because in routine practice, they have to identify what are these disabling deficits. Yeah, Pooja.
So see, disabling deficits, now they have given us some examples, but if I tell you, because you will not be able to remember the list when you are assessing the patients and deciding whether they need to be thrombolized or not. So any deficit which is going to hamper their quality of life, which is going to limit their activities of daily living, is going to be disabling for that particular patient, right? Now, say for example, this complete hemianopsia, right? So there is one half of the vision which is, completely gone, right? So for this, for an elderly patient might be something which we can go on, but for say somebody who's young and who is a pilot, this deficit is going to be very, very severely disabling. So a complete hemianopsia, which if you do NIHS, is just going to give you a score of 2. So that as per NIHS, this is going to be a low stroke, but this is disabling. And if a patient comes to you, you are going to thrombolize. Similarly, if the patient has severe aphasia, or has hemiattention, so his extension, it's he or she is completely not giving attention to one half of the body, or any weakness which is having a limiting their sustained effect against the gravity. So all of these questions, if you see, if you answer them or NIHs, you're just going to get a score of 2 or 3. So they would have been labeled as minor stroke as per the NIH's definition. And we would not have given them thrombolysis, but we need to give them thrombolysis based on the current criteria. Now, on the other hand, we have may not be clearly disabling. So this is where we need to decide based upon our patients, right? So if your patient has a mild aphasia but is able to communicate meaningfully, if your patient has a mild facial drop, but imagine if this patient is someone who has to have a social interaction or somebody who is concerned with the social gathering, so this deficit becomes disabling for them. So yes, you need to keep this list in mind, but you need to take this decision based upon your individual patient as to what deficit will be disabling to them and not, and then decide accordingly.
Right. And so for the 2019 guidelines, what that stated was for mild non-disabling stroke, which means NIHs of 0 to 5, all IV alteplase is not recommended. Okay, even in the 2019. Now 2026, it reaffirms that there is class 3 recommendation against intravenous thrombolysis for such mild non-disabling deficits, but it also makes a specific mention of dual antiplatelet therapy over thrombolysis for this specific population to avoid hemorrhagic risk without functional gain. So this has been specifically mentioned in the guideline. Okay, right. Now coming to the pediatric patients. Well, with regards to pediatric patients, I think if you look at the 2019 guideline, there was no specific subsection for pediatric patients. Okay, this was exclusively for the adult population, but this guideline has a specific section for pediatric patients as well. Very, very important. Now, with regards to thrombolysis, I've got more points coming up with regards to pediatric patients. But first, regarding certain other points that I would like to say about thrombolysis. As I told you, 2019 just limited to adults. 2026 adds specific recommendation to children. So IV alteplase may be considered with a class 2B recommendation for pediatric patients aged 28 days to 18 years with confirmed acute ischemic stroke presenting within 4.5 hours with disabling deficits. While the efficacy is uncertain due to the lack of RCTs, the safety has been established. This is important. And another thing I want to tell you is it's just alteplase because we do not have data regarding tenecteplase. So for the time being, for children, it's alteplase, right? Okay. Now, what about other IV thrombolytics? Are there any mentions in the guideline? Yes. So if you go through the guideline, you see two new additions. One is retiplase and the other is pro-urokinase, but only with a weak recommendation. So the guideline introduces IV retiplase as a consideration for eligible patients within 4.5 hours who are not undergoing endovascular thrombectomy. And also there is mention of IV mutant pro-urokinase, again with class 2B recommendation. And remember, this is only having a weak recommendation. So in your practice, please stick to tenecteplase and alteplase, right? Okay, right. But there are more studies which are going on with these agents, retiplase and pro-urokinase. That is what you have got to understand. Now, regarding mobile stroke units, well, the current guideline recommends the use of mobile stroke units with a class 1 recommendation to administer intravenous thrombolysis faster. So when you have these mobile stroke units, it is more likely that you get the patient within the golden window period. Okay, within 60 minutes, if we do, that is often the best, right? All right. And appropriate transport destination is also important. See, when you have a patient, in the pre-hospital setting, when you're transporting the patient, rapid transport to the most suitable facility is more important rather than simply the nearest hospital. So what often happens is somebody has a stroke, you take him to the nearest primary health center, from there to another health center. So that's not how it should actually happen. The 2019 guideline made a mention that the patient should be transported to the nearest thrombolytic capable facility, but the 2026 guideline endorses a direct transport to the closest endovascular thrombectomy capable hospital if it is available in the premises. Okay, right. And you can even transport provided you're not wasting time for the thrombolysis and it falls in that window. That is what you should be aware about. Okay, right. Now coming to certain pre-treatment guidelines. Okay, pre-treatment guidelines. So 2026 guidelines strengthens the recommendation regarding the diagnostics. All of these were mentioned in the previous guidelines as well, but it is that they've made solid statements. Intravenous thrombolysis should not be delayed for any ECG, troponin, or renal function testing. Additionally, in patients with unknown cerebral microbleed burden, okay, the cerebral microbleed burden, intravenous thrombolysis should be administered without delaying for MRI to count the microbleeds. Okay, because if you have got more than 10 microbleeds, yes, there is more chance of hemorrhagic transformation, but do not delay just waiting for that MRI. Okay, right. Now, regarding endovascular thrombectomy, I think some very, very important points are coming up which you should be knowing. And if you are a medicine resident, listening to this, we'll keep it simple for you. But neurology residents, you will have to read this in depth because you'll have to go to the guideline and read this in depth. And that is what, we'd like to tell you. But let's try to keep it very simple and plain for, the majority of the viewers. So 2019 guidelines, endovascular thrombectomy was restricted to patients with small core infarct, which is defined as an aspect score of more than or equal to 6. And patients with low scores, which indicated larger dead tissue volume, were generally excluded or considered with only uncertain benefit, right? Okay. Now, what happened in the 2026 guideline is basically an expansion of the eligibility for endovascular thrombectomy, which is including even large ischemic stroke. So if you see thrombectomy 0 to 6 hours after the onset of symptoms, aspects 3 to 10, listen to this carefully, aspects 3 to 10. So in patients with acute ischemic stroke from anterior circulation, proximal LVA of the, that is LVO, large vessel occlusion of the ICA or M1, presenting within 6 hours of onset of symptoms with NIHS score more than or equal to 6, pre-stroke MRS of 0 to 1 and an aspects 3 to 10, the endovascular thrombectomy was found to be beneficial with class 1 recommendation. Now, what about in the 6 to 24 hour window? 6 to 24 hour window. So with aspects of 6 to 10 in patients with acute ischemic stroke with an anterior circulation, proximal LVO of the ICA or M1 presenting within 6 to 24 with NIHS more than or equal to 6, pre-stroke MRS 0 to 1 and aspects more than or equal to 6, again class 1 recommendation. Now, thrombectomy 6 to 24 hours with aspects 3 to 5. This is where you have to be careful. In selected patients, okay, not all, in selected patients with acute ischemic stroke from anterior same. But what are these points that you should be aware about? Age of the patient less than 80 years. NIHS score more than or equal to 6. Pre-stroke MRS 0 to 1 and aspects 3 to 5 and without significant mass effect on imaging. Okay, then you will have class 1 recommendation. Okay, so this is something you will have to watch out for. Okay, right. Now, what about, this one? This is again very important. This is entirely new into the guideline where the aspects 0 to 2. In the previous guideline, this was out. You're not even thinking of thrombectomy. But here again, in selected patients with acute ischemic stroke from anterior circulation, proximal LV of the IC or M1 within 6 hours of onset of symptoms, age less than or equal to 8 years, NIHS pre-stroke MRS aspects 0 to 2. But the recommendation is only weak, it's 2A. Okay, not 1. So that is what you have got to know. So basically, I'm trying to tell you is the major change that has happened in endovascular thrombectomy is we are trying to accommodate larger ischemic cores as well. Very, very important point to all of you listening. Large cores are now included as well. Important. Okay, right. Now coming to the posterior circulation strokes involving the basilar artery. What did the 2019 guidelines tell us? The recommendations were weak. Okay, the endovascular thrombectomy for causative occlusion of the basilar artery was considered to be class 2B. May be reasonable with uncertain benefits, but what does the 2026 guideline tell us? So there is a strong class 1 recommendation for patients with basilar artery occlusion presenting within 24 hours of symptom onset with NIHS more than or equal to 10, PC aspects more than or equal to 6. Okay, that is important. Okay. And the guidelines also clarify that for patients with lower severity, that is NIHS 6 to 9. This one was NIHS more than or equal to 10. 6 to 9, endovascular thrombectomy benefits are less established, but may be reasonable class 2B. Okay, right. Okay, right. And regarding medium vessel and distal vessel occlusions, 2019 guidelines, endovascular thrombectomy for M2 or M3 occlusions was given class 2B recommendation without any sort of a distinction between dominant and non-dominant territories. Very important. Listen to us carefully. There was no distinction between dominant and non-dominant territories in the 2019 guidelines. But 2026, based on the recent trials, the recommendations have been redefined. If it is a dominant proximal M2 occlusion, endovascular thrombectomy within 6 hours is reasonable in selected patients with class 2A recommendation. Whereas non-dominant M2, M3 and distal vessel occlusions, endovascular thrombectomy using current stent retriever techniques are not recommended. Did you understand? That's how the comparison you should know, dominant versus non-dominant. This was not there in the 2019. Okay, so this is what you have got to know. And you will have an exophthalmogenic table, medicine residents. So, don't lose your sleep over this. Just learn whatever has been taught, but neurology residents, please go to the guidelines, and go through this. It's very important for you. Okay, so please go through this as well. Okay, right. Now, next regarding the pre-stroke disability. So 2019 guidelines, the eligibility criteria required a pre-stroke MRS of 0 to 1. You remember that, everyone? Yes or no? Let me know in the chat box. You remember this or not? We have also taught you in the guidelines lectures in the app. 2026 recommendations now support endovascular thrombectomy for patients with pre-existing disability as well. Mild disability, MRS 2, EVT with a class 2A recommendation. Moderate disability, MRS 3 to 4, 2B recommendation. Okay, this is what you have got to do, right? Now, peri-procedural management. This is regarding blood pressure. So 2019 guidelines suggested that it was, I'm talking of peri-procedural management of thrombectomy. Okay, that's what I'm talking about, mechanical thrombectomy. So 2019 guidelines said that following the procedure, it was reasonable to maintain a BP less than 180/105 during and after procedures. Okay, but how low can that it be? Is there any cutoff? No mention. No mention in 2019. But in 2026, there is a definite solid mention that intensive systolic blood pressure lowering, if you lower it less than 140 for the first 72 hours after successful reperfusion, then it is harm, class 3. So don't go for intensive BP lowering. That's what I want my children to know. Okay, very important. And what about pediatric patients? What about pediatric patients thrombectomy? We have seen thrombolysis, right? I have got a few more points with regards to blood pressure, but here I'm just talking about thrombectomy. Okay, I'll just come back to this blood pressure again. Okay, so watch out. Pediatric patients and thrombectomy. 2019, as you all know, guideline was for adults. Okay, but here, age more than or equal to 6 years, endovascular thrombectomy can be effective with class 2A recommendation for LVO within 6 hours and 6 to 24 hours. But if the age is less than 6 years, endovascular thrombectomy may be reasonable with class 2B recommendation when performed by experienced neurointerventionists dealing with those sort of cases. Pooja, if you can just go through this particular slide as well.
So you see how aggressive we have gone now. So we have gone as low as even 28 days. So yes, definitely less than 28 days, we are not going to do any sort of procedure in them. But beyond 28 days, up to 5 years, right? So that is where if you have an LVO which is present with
I
us.
think there is a connection problem. Is it in my end or let me just check? Yeah, Pooja, am I audible?
Yes, sir.
Yeah, I think in between I lost connection. Okay, right. I think even the internet got a bit shaky hearing all these guidelines. So, all right. So I think Pooja has explained regarding this. And next, coming to imaging and evaluation in children. Okay, this is again something that you all should just look at this because look, unlike adults where the non-contrast CT is the standard. Okay, herein for children, emergent MRI with MR angio of the cervical and intracranial vessels is considered reasonable with class 2A recommendation for children to identify large vessel occlusion, and especially because, why? Because in children, there are more chances of stroke mimics. So you'll have to differentiate it from stroke mimics. So there is also a CT alternative to it. That is, if the MRI is not available immediately, that is within 25 minutes, proceeding with CT angio is reasonable with class 2A recommendation. So this is within 25 minutes. Okay, right. So that is also clear for you. Now coming to general supportive care. So hope all of you are with us. Just a few more minutes. Okay, we are just closing. Okay, so don't worry. The lighter part is coming up. So this is regarding post-reperfusion blood pressure lowering. So I think, Pooja, you can just compare and contrast IVT and endovascular thrombectomy regarding the post-reperfusion BP lowering. Right.
Okay. So this is something which is extremely important because as residents, I was always asked this question by my ICU team that, okay, you have said that lower it to less than 180 by 105, but how much lower should we take it, doctor? Can we take it to 110 and 120? And I was always confused. I had no answer to give them ever. So I think these guidelines give you that answer. So as you all know that post thrombolysis, your blood pressure monitoring is extremely important, right? So the target it has to be less than 180 by 105, and this has to be maintained for the first 24 hours after the IVT treatment. So this is something we already had from 2019 guidelines. So what is 2026 given us extra? It has given us extra that we don't have to be very intensive with this blood pressure lowering, right? We do not have to take it to less than 140 milligrams as well, right? So it's not associated with any improvement in functional outcome. Now notice that this in IV thrombolysis is category 3 saying no benefit. But once you have taken your patient for an endovascular thrombectomy, again the targets are more or less the same. So you have the same target of maintaining it to less than 180 by 105. You don't have to be aggressive and reduce it to less than 140, but that is even up to 72 hours. And remember that this is in endovascular thrombectomy is a harmful recommendation. So this is something which has to be avoided extremely. And the reason behind is that whenever you're maintaining the blood pressure as this flow, you are actually trying to perfuse whatever area that you can in the salvageable brain junctions. So remember that the BP target is less than 180 by 105, number one. Number two, you don't have to be too aggressive and bring it down to less than 140, whether be it IV thrombolysis or endovascular. And in endovascular, especially, it is associated with a bigger harm.
So I think, Pooja, it's important for students to remember this 140, right? Which is
Yes.
not there in the previous guidelines. So you have to keep this in your mind, 140. Okay, keep that in your mind. Medicine residents also, please take care. Okay. Now, with regards to blood glucose management, 2019 guidelines recommended that treating hyperglycemia to achieve levels 140 to 180. The current guidelines also maintains the same level, but adds a specific class 3 recommendation against intensive insulin treatment targeting a value of 80 to 130 because of higher incidence of hypoglycemia. Okay, that's what you should be knowing. Now, next is regarding the initiation of anticoagulation. So I've told in my lectures as well in the DocTutorials app that we have got different guidelines, the European guidelines as well as AHASA guidelines for the initiation of anticoagulant. If you remember, as per the 2019 guidelines of the AHASA, for anticoagulation, it was 4 to 14 days. You remember that? 4 to 14 days was the recommendation after the onset of neurologic symptoms. Now, the same applies here in the 2026, but it introduces a new class 2A recommendation supporting a strategy of early oral anticoagulation within 48 hours, but in some patients, carefully selected patients with minor or moderate stroke. Okay, so in such a small subset of patients, they have introduced early oral anticoagulation. Okay, with only class 2A recommendation only. Okay, that is what you should be knowing, right? All right. Now, with regards to dual antiplatelet therapy, what you should be knowing, it's about extended time window. So we know that for the dual antiplatelet therapy, the 2026 guideline, what it says is that aspirin plus clopidogrel initiated within 24 hours remains class 1. Okay, that is just like 2019 guideline itself, no change. But there is another class 2A recommendation added for initiating the dual antiplatelet. I'm talking about minor stroke. Okay, I am talking about minor stroke. You know that the role of dual antiplatelet is for minor stroke. TIA and minor stroke, you can go for dual antiplatelet for the first 21 days. So if for starting the dual antiplatelet, it has to be started within 24 hours with class 1 recommendation, just like in 2019 guideline. But even if you start at 24 to 72 hours, suppose there is a delay, even that has a class 2A recommendation. That is a new addition in the latest guidelines is what you should be knowing. Okay, right. Now, with regards to ticagrelor, so the 2026 guidelines now includes ticagrelor, not as monotherapy, but as an alternative to clopidogrel in dual antiplatelet regimens. Okay, that is what you should be knowing. Okay, in the 2026 guidelines. Okay, right. Now, I think we have summed up all the necessary points of the guidelines. I hope all my dear children, you would have enjoyed this. I at least hope, I don't think you will enjoy guidelines, but at least we hope. We'll be sharing this PDF with you in the group, but we have tried our best to simplify the guidelines. And, reading the guidelines is not that easy. We also have to read it first. Pooja is still young but I am just growing old, I assume. So I also had to, spend some time to read and understand all this. Okay, so anyway, I think we have just tried to summarize what is best possible for you. And we have gone at a fast pace just to save your time, because I don't think, you like watching long lectures. If there are any more queries, we'll take it in the group as well. If there are any quick queries in the chat box, I think we'll keep the session a crisp one. You can come back to us in our WhatsApp groups. As I've told you, you can just inbox me in my Instagram. I'll be sending you the link to our groups. So myself, Dr. Pooja, we are all available. We have got separate groups for the NEET preparations as well as for residency. So, in the residency groups also, we'll be keeping on sharing, cases, case-based scenarios, and stay tuned to this YouTube channel for more such videos as well. And we have got the DocTutorials residency program. Pooja has also done some wonderful examination videos, because all the time medicine residents ask me, sir, how to do neurological examination properly. I think, you've got someone who has done DM neurology from AIIMS Delhi showing you the proper method of how to do the neurological examination. So all of you do watch the videos as well in the DocTutorials app. So thank you so much, everyone, for joining. Okay, somebody is asking dual antiplatelet after 24 hours. No. Dual antiplatelet is for minor stroke. No, there you are not thrombolizing. Okay, Dual antiplatelet is routinely not given in stroke, only in certain exceptional scenarios like minor stroke or high risk TAA where you're not thrombolizing and you're starting dual antiplatelet. But otherwise, if you're talking about starting off single antiplatelet after stroke, yes, it is after 24 hours. So thank you so much, Pooja, also for joining in this session and also for the effort that you have taken. So thank you so much, everyone, for this wonderful discussion. Thank you so much. So we'll continue our discussion in the groups and stay tuned. Thank you so much. Bye-bye.
Thank you, sir. Thank you.